Advocates for Community Health is a membership organization for large federally qualified health centers, or FQHCs. We strive to advance the delivery of healthcare to underserved populations and achieve health equity for patients in need. Our members span the country and provide comprehensive primary care to millions of Americans, regardless of their insurance status or their ability to pay. We launched ACH last summer, and we've been advocating on Capitol Hill with relevant leaders in the Biden administration and across agencies to ensure that community health centers have funding, resources, and the support that they need to continue to serve underserved and disenfranchised populations nationwide. I'm really excited for the conversation this morning. I am joined by an incredibly talented and very, very wise panel of leaders across our membership, a few of our members. Here with me today is Dr. Amanda Asher from Sun River Health in New York, Carrie Hydash, the CEO from Family Healthcare Network in California, and Dr. Parinda Khatri from Cherokee Health Systems in Tennessee. They're here to talk about the workforce shortage crisis health centers are experiencing and what that means for our most vulnerable populations as they continue to do their critical work on the front lines to provide care to all those in need through the pandemic. We'll also share some of our policy recommendations for Congress and the Biden administration as talks continue on Capitol Hill around Build Back Better, and also looking forward at a more visionary approach to transform the healthcare system as a whole. Some of you may not be very familiar with federally qualified health centers, though they're near and dear to us. I do want to just take a second to help give a little context and history around FQHCs, which we affectionately call community health centers or health centers. I want to explain some of the work that they do. And so I want to kick this off with a little context, like I said. So federally qualified health centers are community-based. They provide comprehensive, culturally competent primary care in medically underserved areas. Think of one-stop shopping for primary care services under one roof. Health centers receive grant funding from the Health Resources and Services Administration, HRSA, and the Bureau of Primary Health Care. The health center program launched more than 55 years ago, and today includes nearly 1,400 health center grantees in every state and territory in the country. 1 in 11 Americans receive their health care from their local FQHC or their health center. In fact, health centers are the largest network of primary care providers in the country. Health centers are unique in that they're community embedded, both employing members of the community and including them in their boards. In fact, something that's very special and really at the heart of health centers is the fact that all health centers are required to maintain a 51% consumer majority governing board. The wisdom being that community and the very patients that are being served should help to guide and lead the programming and services provided to be truly responsive to their communities and the needs that they're experiencing. It's worth noting that health centers are located in areas of high needs where economic, geographic, and cultural barriers otherwise limit access to affordable care. FQHCs serve as hyper-local healthcare hubs that deliver comprehensive, culturally competent, and high-quality primary healthcare. And beyond that, they also provide health education, translation, transportation, and other essential needs to their patients. Again, think of all of the possible needs under one roof and one organization. Health centers bring preventive services and comprehensive care to uninsured and underinsured, low-income, rural, and marginalized communities that often have no alternative source for medical care. In fact, 90% of health center patients are at or below 200% of federal poverty level. One of the most amazing traits of FQHCs is that their model of care enables them to have improved patient health outcomes at lower costs, despite treating populations experiencing more chronic illness, complex health issues, and financial equity than other healthcare providers. Throughout the COVID-19 pandemic, community health centers have been on the front lines. They've been instrumental, in fact, in providing testing, vaccinations, continued comprehensive care for populations in need. In 2021, health centers administered more than 13 million vaccines and 12 million COVID tests, the majority of which were delivered to BIPOC communities, and these numbers continue to climb daily. While health centers have faced significant challenges throughout the pandemic, they've remained committed to providing high quality, essential primary healthcare to the country's underserved and vulnerable populations. 79% of health centers met or exceeded national clinical benchmarks in 2020 and increasingly improved patient outcomes while also lowering costs for patients and the system as a whole. Health centers employ more than 250,000 people. They spur local economies and save the healthcare system $24 billion annually. This is an important figure when you think about the world that we're living in right now. These organizations employ a diverse workforce that reflects the communities they serve, and that workforce, like healthcare staff nationwide, is overstretched and experiencing extreme burnout. And this is part of the reason for our conversation today. A hallmark of the health center program is health equity. Health centers have been at the forefront of the pursuit for health equity since their inception, incorporating programming and services to address health disparities and achieve health equity from day one. This work and focus continues today. And one area that needs support and attention is the vital need to invest in health center workforce, a crucial element to building a more equitable healthcare system. We're very grateful to HRSA, the agency, as I mentioned, that oversees the health center program, and the Biden administration for providing almost $9.3 billion in new funding to support health centers as they respond to the pandemic. However, the workforce crisis health centers are experiencing will require more than emergency funding. In fact, the healthcare workforce issue was a major challenge prior to the pandemic. It's the pandemic that has inflamed and exacerbated this issue. We need significant investments in our infrastructure and to build workforce pipeline that allows us to address the growing need in the communities we serve. The Build Back Better Act includes critical funding for health center infrastructure and workforce development. But as Congress struggles to reach an agreement on the legislation, urgent funding for health centers is hanging in the balance. Specifically, within Build Back Better, this includes $2 billion for health center infrastructure, $3.37 billion for the Teaching Health Center GME program, and $2 billion for the National Health Service Corps, and $200 million for the Nurse Corps. Each of these investments are critical for health centers and the operations and caring for the communities that they serve. Health centers are very fortunate to have a long and deep history of bipartisan support in Congress and across many administrations. Whether through Build Back Better or some other vehicle, health centers urgently need this funding, particularly as the most recent COVID surge exacerbated an already stressed workforce. And while this funding to address present challenges is critical, Advocates for Community Health envisions a healthcare system and a network of health centers with a robust and diverse workforce reflective of the patients and the communities they serve. We're asking for Congress and the Biden administration to strengthen frontline provider resilience by funding for evidence-based interventions at community health centers to ensure that providers are connected to behavioral health resources and peer support. We're asking that support be provided to reduce barriers to provider loan forgiveness by providing guaranteed loan forgiveness eligibility for providers working in FQHCs, and or to provide allotments to FQHCs through 330 grants to provide clinicians and to be provided for clinicians and other eligible staff. We're asking that the workforce be prioritized and that diversity within the workforce be prioritized through data, evaluation, and funding by empowering HRSA, which is the entity that oversees health centers, to require FQHCs to submit data on race, ethnicity, sexual orientation, gender identity, and disability status of their workforce, and to establish a pool of funding to ensure that health centers are able to recruit and hire a diverse staff. We're asking to continue to invest in the teaching health center model with $6 billion in funding and by providing funds to interested health centers to cover startup costs and to provide funds for sustainability beyond the number of residents. Over the past 10 years, the Teaching Health Center GME program has supported the training of nearly 1,200 new primary care physicians and dentists. The Teaching Health Center model, where physicians train in community health centers, has proven wildly successful. We need to learn from it and work to modernize the way we train physicians to meet the needs of patients today, who are seen far more often in an outpatient setting. Health centers are best positioned to train tomorrow's workforce who will meet the urgent call for health equity. And with this in mind, we're asking that Congress and the administration integrate FQHCs more fully into graduate medical education by reducing barriers and providing incentives for FQHCs to partner on GME funding. We're also asking to improve and expand the workforce pipeline for FQHCs by increasing funding for top programs and in collaboration with the Department of Labor and the Department of Education that can support FQHC workforce and pipeline, including community college partnerships and apprenticeship programs. We're asking that resources be established and to disseminate leadership training and incentives for FQHC workforce by developing standardized leadership training to encourage and facilitate career ladder mobility within health centers. That's a lot. Those are all part of our priorities just under the workforce umbrella. But each of these solutions and proposals will move health centers and the nation in the correct direction to address some of the workforce crisis that we are experiencing, which, as I said, was present before the pandemic and has only been worsened as a result. Before I open it up for our panelists to share their remarks, I just want to say a special thank you to the National Press Club for being such an amazing partner and providing this platform for us to use and have this important conversation. And now I'm going to pass it over to Dr. Asher, Dr. Khatri, and Ms. Haidash, who will share a little bit more about what they're seeing at their individual health centers and among their colleagues before we jump into our panel discussion. So Dr. Asher, I will turn it over to you.
Thanks, Amanda. I'm Amanda Fallick Asher, the Chief Medical Officer of Sun River Health. Sun River Health was founded in 1975 by 4 African-American women, our founding mothers, in Peekskill, New York, to bring health equity to their community and their children. Since then, we've grown into a network of 43 health centers throughout the Hudson Valley, New York City, and Long Island, covering the rural and inner city regions of New York State. We provide comprehensive health care, including primary care for adults and children, women's health, behavioral health, dental health, podiatry, optometry, substance use treatment, adult day health care, HIV care and prevention, nutrition services, urgent care services, hepatitis C treatment, and we care for special populations, including the homeless and migrant farm workers. When Amanda said we were one-stop shopping, she wasn't kidding. With our staff, subsidiaries, and partners, we offer a wide web of social supports to help address social determinants of health, knowing that 80% of health outcomes are driven by non-healthcare determinants, including housing, food and financial insecurity, access to transportation, and the school to prison pipeline. Our staff come to work for us because they understand what we're doing for our communities, for their communities. And we all appreciate that the pandemic has highlighted healthcare inequities, but I see the meaning of that sentence on the faces of our staff every day across our system. They are brave. They're working for us for the right reasons, and today they are exhausted. After a 2-year pandemic, which is now endemic, they're still working more hours while we lose potential candidates because commercial health and large hospital systems pay more. Sometimes Walmart pays more. In other words, staff are going to other networks who bring healthcare to the commercially insured. They're going to provide healthcare in wealthier communities. That's the equation, and it's an unjust equation. None of us blame the staff for making these decisions. They're staring down school loans and monthly bills they're providing for their families. However a noble person you are, it becomes difficult to make a choice for lower pay. What must change is the set of incentives we can provide. Community healthcare centers must be able to differentiate ourselves in a positive way within the market. And to do that, we simply need more cards to play. We need to help stack the deck in our favor. Why does it matter? Because the model for community health is one that is of the community and for the community. If I'm growing up in Wyandanch or Peekskill or the Bronx or anywhere in this country, and I'm a patient of a federally qualified health center, I need to understand what career paths can lead me onto one of those staffs and eventually to one of those leadership positions. Our chief of staff started her career as a waiter. She was a patient in another health center in New York and always wanted a career in healthcare. but she was a dreamer. When her DACA status was solidified, she knew she could go back to school and pursue her dream of providing healthcare to those who had cared for her. Our CEO happened to be a regular at her restaurant, and they became friendly. Diana asked Ann Nolan, our CEO, "Do you have openings for someone who's completely naive to healthcare?" She started as an assistant and, in her words, a coffee fetcher, and returned to school to become a nurse midwife. She's now our chief of staff. This is an amazing story, but we can't rely on luck, connections, and who you know to staff our health centers. We need to build pathways into community health, like the National Health Service Corps, like graduate medical education, like nursing pipelines. We need that awareness so people understand the path to join us. And we need it now because our staff are so tired. As many staff as we hire, we lose the same number of staff in the same time period. We are literally hemorrhaging, and you can only do so much more with less. Thank you.
Thank you so much, Dr. Asher. I get chills when I hear about those stories in terms of how people come up through the community. This is something that we see and we hear at health centers over and over and over again. And it's an incredible indication of the connections and the relationships they have with their patients and deeply within their communities. So I applaud Anne and the entire Sun River team for helping to make those connections. But I think you're right. There needs to be more done to contribute and create opportunity, pipeline resources, policy, and programming so that it isn't just sort of one-off scenarios. And it's a more deliberate investment on the part of our nation's leaders to ensure that that's a part of the programming in a consistent way. So with that, I'm going to turn it over to Dr. Khatri to share from her perspective.
Thank you. And Dr. Asher, that was inspiring and certainly could resonate and connect with so many of your points. Thank you all for taking the time to listen to our story and a little bit about our journey. Cherokee Health Systems is a federally qualified health center. We're also a licensed community mental health center and a licensed alcohol and drug treatment facility. We say we're the hybrid safety net. And in fact, Cherokee Health Systems was started in 1968 as a child guidance center, a community mental health center for children. And as we grew and developed, we went into communities where nobody would see our patients for medical care. They would say, oh, they have a mental health diagnosis. And we recognized that people were showing up at our doorstep needing more and asking for more. So we really grew around our community. Our patients in our community showed us the way. So we then added primary care services, comprehensive primary care services, learned a lot, expanded our substance use disorder treatment services. And because of the need was so great, we responded in every way we could. So I often say that it's not brilliance that causes us to do different things, it's desperation. So we would go into a community and we desperately needed dental services. So we built out dental services. As Dr. Asher mentioned, workforce is a massive issue for us. We cannot pay what other, even public infrastructure, public government jobs pay with the benefits and pensions, and certainly private practice. And people who work for us often come from the community. We go into a community and we do not presume to know what the community needs. We hire from within the community. We have board members from the community. And what we want is to have a community-based entity that is more than a health clinic. We provide healthcare services, but we are so embedded. We have partnerships with schools. We have partnerships with food banks. Our food pantry, every clinic has a food pantry. We give out clothing. We have connections with transportation facilities, churches. So we have built this kind of community infrastructure to help meet the need. but the demand is unrelenting, and we just don't have enough people who are able to participate in this community response. You know, as Dr. Asher said, during this pandemic, it has been absolutely devastating to see people who have tears in their eyes saying, I don't want to leave here. I love my patients. I love what we do, but I can make $2 more an hour, which is huge for them, working at an eye doctor's office or at another, frankly, retail or even fast food environment. And we're certainly lean and mean. We work incredibly hard. We do not have any more additional layers than we need to. But through this, we are being as creative as possible. You know, one thing that we have done that really is aligned with this legislative ask is we have become a learning health system. So we realized people were not just showing up at our doorstep, providers, staff at every level. So for the past 40 years, we have systematically built up partnerships for workforce. We partner with medical centers, medical schools, psychology, clinical social work, nutrition, pharmacy, public health, to help grow our own. And in fact, as Dr. Asher said, we have these wonderful stories of people who worked with us, did a rotation with us, and they really fell in love with the work, and we fell in love with them. And so this learning health, becoming a learning health system, requires a lot of infrastructure. We need to provide supervision. We need to take time for teaching. When we have medical students coming through our system, or residents, or practicum students in psychology, social work, we don't get any money from the academic institutions. We get nothing. We are blocking our clinical time, which is our source of basically funding, and making the decision to do teaching because we want people to connect with the beauty and joy and meaning of the work that we do. So as a community health center, we become a learning health center. We are community-based. And I also want to highlight the clinical quality that is provided. If you go to most private practices, they have very few quality metrics they have to track and report to so many people the way community health centers do. So we are tracking clinical quality metrics at a level and a pace and a rigor that is truly remarkable. And these clinical quality metrics are transparent. Anyone can go online and go on HRSA's website and see, how is this organization managing diabetes? How is this clinic managing hypertension? We are held to a very high standard, and that drive for excellence combined with the mission and meaning of what we're doing really exemplifies, I think, everything that we want to provide for our community members across this country. So, the passion we have, the commitment we had is tremendous. We need to do more. We need help to do more. And I think that, by growing this model, growing our resources and what we can do, it can be a very powerful agent, not just for health and well-being, but frankly, the economy, the educational system, and the community connectedness that I think a lot of people have both found to be sometimes ripped apart, particularly during this pandemic, and also sometimes brought together. And we have really kind of witnessed the best and worst of what our communities can do. Let's focus and build on the best. So thank you.
Thank you so much, Dr. Khatri. Again, this is what happens. You guys give me chills when you start talking about all the incredible work that you guys are doing and your teams, the way you're reaching across your community. I would just stress the connection to health equity as well, just to build off of what Dr. Khatri is saying. All of this work, and really since the inception, as I started with, is about achieving health equity. It's about addressing health disparities. The quality metrics that Dr. Khatri is talking about, this is a standard that's a part of the health center program that every single organization has to report on and track. And so when we talk about improved health outcomes, we have the data to back that up. And when we talk about the quality of care being exceptional at health centers, especially by comparison across the healthcare sector, private providers, you name it, there's truth and there's data to back that up. And it's certainly a sense of pride for me. I'm so inspired by our speakers and our panelists, but truly that's the story of the health center program. And this is across the network as a whole. And again, bringing it back to health equity, when you consider the fact that health centers exist within underserved communities, medically underserved communities, marginalized communities, the health disparities that exist within these communities, all of this translates to achieving and moving in the direction of health equity, but they need help, and the workforce piece of this is massive. When we think about the challenges to staff up, and what does that mean? If you don't have the staff to provide the services and to continue your operations, there's a barrier to access. And if these populations are those that are experiencing the highest level of disparity and experiencing health inequity at its worst, if you don't provide the resources and the support to create opportunities to bring in that workforce, it then becomes not just an access issue, but a health equity issue. And so health centers are really incredibly positioned to be able to move us forward in all of this direction, achieving health equity. But again, in spite of how incredible they are, and they always figure it out, we need additional support and resources. And frankly, we need visionary policy that's going to bring us into the next generation, which is why ACH is here and why we're having this conversation. And with that, I want to open it up to Ms. Carrie Hydash. She's the CEO of Family Healthcare Network in California. I know she's got some incredible experiences and reflections to share as well. So Carrie?
Thank you, Amanda. As Amanda said, my name is Carrie Hydash. I'm the president and CEO of Family Healthcare Network in Central California. Family Healthcare Network was established in 1976 in a small gas station in Porterville. We've grown today to be a network across 3 counties, serving out of 42 sites, serving nearly 240,000 unique users every year. Some of our sites are an hour and a half away from each other, so we're very spread out. And so we're major players in very small communities. And we're really responding to community, as everyone that spoke before me has said. And I'll try not to repeat everything they said, but I think it's important to point out that we're all diverse networks of comprehensive outpatient services that are community driven based on community need. We're also some of the largest employers for those same communities. Some of those same at-risk individuals come to work for us and for the first time have comprehensive benefits, have pathways to jobs that help sustain their families. So we're both supporting patients and community in the work that we do. Family Healthcare Network, besides being an outpatient provider, is a full scope provider for inpatient care as well. So we have an adult hospitalist program. We have pediatricians who round in the hospital, full OBGYN program. We deliver half the infants in one of the counties we're in. We're caring for patients in 4 hospitals across the counties that we're in. So through the pandemic, we not only worked to meet the outpatient needs of the community, but we were inpatient caring for COVID patients. What we saw really was that our partnerships deepened during the pandemic, because as we know, public health was very stretched. And so FQHCs who are trusted by communities, trusted by patients, were asked to step up, and we were proud to step up to help to make sure that testing occurred, vaccination occurred, and also some of the traditional community outreach that we all partake in as FQHCs, our traditional literacy programs or food distribution programs all became that much more vital as we saw disparities grow for our patients. All of a sudden, patients didn't have typical transportation. Patients who were able to before get free food at school were now at home without access to food. And so it was up to us as FQHCs to step up and say, we will be there for patients, move food distribution to us. Community health teams that have traditionally worked on outreach programs and enrollment, here's an iPad, go out to the fields and make sure we're connecting farm workers to care, or go out to homeless encampments and connect homeless individuals to care. How do we innovate to make sure that we're spreading our resources was top of mind throughout the entire pandemic. So in what I guess I'm trying to say is that we started doing more. We became creative and innovated at a time when we had less staff. because our staff were also impacted by these barriers. They had children at home. They were being exposed to COVID and having to quarantine. So for FHCN, what that looked like is a lot of new programs, vital programs for community, increased volume, where we typically would see 4,000 patients in a day on an outpatient, in the outpatient setting. We're seeing 5,000 patients a day. We have lines out the door every morning of individuals who are walking in for testing because they need to get back to work. They need to make sure they're safe to be home with their children. So our staffing has gone down. The volume of our patient needs has gone up. The volume and demand for our wraparound community-based services has gone up. And we need help to fund staffing to help keep new staff coming in, training programs, and we need funding and stability for the next pandemic or emergency response, because we know that FQHCs, this pandemic has demonstrated FQHCs are going to be a part of whatever that response is for the next emergency.
Thank you so much, Carrie. Again, first of all, thank you, all three of you, because you and your teams are really, when we say on the front lines, it couldn't be more accurate. And, I think when I think back to the early days of the pandemic and the role that health centers played and the incredible commitment and dedication that health center teams had to show up at a time where there were very few answers, where the risk was incredibly high, where there was frankly inadequate PPE, and people were showing up to make sure that their communities were cared for, to make sure that access was not disrupted. And I think some of the stories that our panelists have just shared around, it's what we think of as, comprehensive traditional primary care, but it's so much more than that. There's so many social determinants of health that factor into the approach and the operations and the delivery of care. So whether it's addressing food deserts and addressing nutrition, it could be substance use, it could be transportation, it's cultural competence. These are all a part of the everyday operations that each of these incredible panelists and their teams deal with and address every single day. And that's the story of health centers. But again, bringing it back around to workforce, the challenge to make sure that the staffing is in place, that they have the resources they need to be able to continue this critical work is not where it needs to be. And so I want to open up for a bit of a panel Q&A. I would also encourage, if folks have questions, they can submit those, I think, in the chat, and we'll be taking those up as well. But I want to start with just one question for the panel here. We're having conversations today, obviously, because health centers like yours need congressional action yesterday, urgently, and more than ever. But I'm curious if you can speak to what the most impactful investment or policy change for your health center would be today, certainly in the context of workforce, but sort of if you had that magic wand, what does it look like? What would it be for your health center to provide the relief, but also just generally to add that support? Dr. Asher, do you want to speak first on this one?
Sure. The list is really long. So the most impactful is hard. I think there are lots of things that would be impactful. I think, we've talked about National Health Service Corps funding. That's available to clinicians and nurses. But I think we need a stream of funding for other staff as well. And we need that funding to be permanent and easier to get. This year, there was an increase in funding available to part-time clinicians, which is fantastic. There should be rolling acceptance into that program. There shouldn't be a deadline. That's a very, very big one. But we also, again, we need an investment in advertising that. I didn't know about that coming out of residency. I trained in an inner city academic health center that served very much the same population that federally qualified health centers serve today. And I was looking for a federally qualified health center to work in afterwards. I just didn't know it. And I'm thrilled my path took me to the world of community health centers. But I think there are lots of folks looking for us. And so it's not just, there's a combination of making the funding available, but also really highlighting the pathway to us in a different way. While I don't know how much time I have, but I do want to speak also that New York State has some different restrictions that other states do that make it a little harder for us staffing wise. So in New York, medical assistants can't do injections. They have a different scope of practice than in other states. And that means we need to look for LPNs and RNs. So we're looking for a different level of licensure at a different pay scale, right? And then our staffing model gets a little bit harder to maintain, especially now with the nursing shortage, right? There was a nursing shortage before COVID. Now there's a nursing shortage for two reasons. First of all, because hospitals are short, they're paying very, very high wages to travel nurses, including basically all of their living expenses, and because nurses themselves are getting sick and needing to quarantine, right? So there's a double whammy right now that there was a nursing shortage before. So in New York State, that's a specific problem. And we also have other licensing problems. We can't use LMHCs in the Article 28, where we provide behavioral health and the physical in the traditional primary care space, only if it's in a mental health setting. I would say right now we have good payment for telehealth in the behavioral health setting. That can't go away. And specifically telephonic. Our patient population cannot necessarily, they don't have free data. They don't have free Wi-Fi. If they have a data plan, they don't necessarily want to use so much of it on this visit. So expanding both access to telehealth and payments to various models of telehealth, that includes telephonic models, matters too. I'm sorry, I took a long time.
No,
I told you the list was long.
Don't apologize a bit. I mean, this is why we're having this conversation. And actually, you're hitting on a question I'm going to bring up in a minute. So you're kind of bringing us through. But I do want Dr. Khatri and Carrie to weigh in as well, just in terms of kind of, again, the question just being, what would the most impactful investment look like? You know, if you had that magic wand, you know, obviously there's the urgent need right now, but thinking that, but also just bigger, what does it look like? Dr. Khatri, do you want to weigh in for a moment?
Yes, I mean, as I'd mentioned, you know, we are a learning health center, and I actually think FQHCs are terrific learning settings. You know, you kind of see everything. If there's a team-based approach, you know, in our organization, and I think it's, you know, become standard in FQHCs, we integrate primary care, behavioral health, clinical pharmacy. So that brings such a depth to learning. But we really don't have a funding infrastructure for that. So we are actually not even a teaching health center, in part because we don't have the infrastructure. You know, what that requires is administrative infrastructure. And remember, we're lean and mean. We are in Tennessee. Tennessee did not expand Medicaid. So we 30% uninsured. Think about that. Think about that when you have health centers, you know, even in other states or places. Imagine any practice where you did not get paid for a third of your patients. So that diminishes our ability to invest in something like becoming a teaching health center. Every dime we have is going to help support care for our patients who don't have resources or even, you know, or insurance. So any infrastructure support that we can get, you know, I think it's wonderful to have a program that supports education and training of the healthcare professions. But sometimes if you create a lot of structure around it or regulation, and then you're not sure of funding, then it becomes hard because there is no guarantee for a teaching health center. So I think that's I think a really important point for us. That would be a force multiplier, frankly, for us in terms of expanding our workforce.
Thank you so much. And that's actually something we hear, quite frankly, a lot from across our network and our membership, that, the Teaching Health Center program is incredible and it's proof positive that this is the direction that we need to go in. But we do need that predictability and the sustainability. I think for a lot of folks, without that assurance that beyond just a couple of years of funding, that they can rely on that program continuing and those dollars continuing to come in, the risk and the worry around operationally what that looks like for the organization, and frankly what it means for their students, serves as a barrier. And so that's one of the pieces that we really, I think, need to address and want for Congress and the administration to be thinking about as we're working through the workforce challenges. Carrie, I'd love to hear from you too. Just what does it look like where you're coming from?
Absolutely. So I completely agree with both of my co-panelists, and I won't repeat what they've said, but their points are solid and important to FHCN. I would also add that innovative ways to elevate frontline staff would be important for FQHCs. We have this interesting model in FQHCs where we have a lot of doctoral level employees and a lot of associate level employees. And those employees are passionate about our patients. They're talented, they're gifted, but many of them are single parents, young parents. They can't, even if they can get scholarships for school, they can't give up working because they have family responsibilities. Innovative programs like scholarships where somebody could work part-time for an FQHC and go to school part-time and have some living funding incorporated through that as a scholarship through an FQ, and other approaches similar to that, where we can capitalize on an already invested workforce to grow within the system and become providers or higher level employees and organizations, would be phenomenal.
Agreed. There are so many pieces here. I think we just got a question about some of the policy proposals, and happy to go back through those at the end. I do want to keep going with the panel here, but I would also say we're happy to provide specifics for anybody that may have missed that beginning portion there. One of the things that Dr. Asher brought up that I think is so important, and it touches on so many different pieces, whether it be health equity or access or solvency, is that the pandemic has led a lot of healthcare providers and health centers in particular to shift to offering more remote services and finding innovative ways to be able to provide the comprehensive care that's what you do for your patients. But I'm curious if you all can speak to how that's impacted your workforce and your ability to serve kind of rural, low income, and marginalized patients and populations. What does it look like at your organization? I think just to kind of start us off and sort of echo what Dr. Asher mentioned, the reality for a lot of the patients being served by health centers is they don't necessarily have a smartphone or a tablet or Wi-Fi. They may not even have broadband. And so the reality for our patient base is different just right off the bat. And so some of the things that have been put in place, thankfully, during this emergency situation, really we're looking for that to be extended permanently. But I'd love for you guys to speak to just what transitions have looked like up to this point, what things you'd like to see continue, and really what's made a difference in serving for your population through the pandemic and sort of looking forward. So we'll go in the same order. Dr. Asher, do you want to start?
Sure. I actually want to start by talking about the fact that there's a double-edged sword here. While we're thrilled to be able to offer a hybrid model for our patients, it really does have to be hybrid, in part because of the data issues we've talked about. Our patients tend to have smartphones. I would say our older patients tend not to know how to use them to connect to a televideo visit. And because of HIPAA compliance and all sorts of regulatory issues, we need to use special platforms. I can't just FaceTime with patients, which would be great and easy, but wouldn't be compliant, and we need to be compliant. But on the other side, the behavioral health remote world on the commercial side has boomed, beyond boomed, exploded. And so we cannot recruit for positions where we want a hybrid model. Some patients don't do well on video. Some patients have trouble confiding with their provider on video. Some patients don't have access to what we talked about. They usually have a smartphone unless they're very elderly. And even then, an adult child has a tablet or something for them to use, but they still might not be able to connect. And we can't offer fully remote positions to our behavioral health team. We never could for physical health, right? Sometimes you just really need to listen to somebody's hearts and lungs and push on their belly. But we are having just a tremendously difficult time recruiting for behavioral health because our folks are going to work, in their pajama bottoms and slippers, the hours they want to work, and, billing privately upwards of $200 an hour. And we can't compete with that because we're not getting reimbursed at those rates.
Thank you. Yeah, it's just a reminder that, some of the investments, and I'll go back to them sort of before we wrap up here, but some of the investments that we're looking for, especially around infrastructure and some of these issues, is just more critical than ever. Dr. Khatri, do you want to weigh in and sort of what the experience has been at Cherokee?
Yes, and I want to highlight the value and the importance of a hybrid model. Having flexibility is really what has been critical, because some patients do want to come in, some patients do need to come in. I will say, it's interesting for us because we serve a mix of urban and rural populations. So we are in 13 counties. We are in urban cities. We have health centers in the inner city that are adjacent to homeless shelters and other entities that are serving populations who are unhoused. We are also a migrant health center. We have clinics in the Appalachian Mountains where I can't even get cell phone service. We know we need a 4-wheel drive and we'll be out of pocket. There is no cell phone service. There are entire miles and miles of mountains where there is no internet and no cell phone service. And it will take, even when you look at one county, Sevier County, where Dolly Parton grew up, it is 4 hours from one end to the other because of mountains. So if you are someone who does not have a smartphone, and a huge percentage of our patients do not have smartphones, but digital health literacy is also an issue. 40% of our patients don't have an email address. So what we, even just to think about just setting up a Zoom, you need to email someone a link, and how do you use the link? So we had to focus on digital health literacy. And then even once we had that, if they don't have internet, there's nothing that we can do. We have families who we've been serving in counties. They had to take their kids to the Walmart parking lot to go to virtual school, or a local church had to pull together and create a point of internet access for their kids to go to virtual school. I mean, this is the United States in 2021, 2022. So for us, the flexibility has been critical. We have patients who are elderly. There is no hospital in their county. There is no hospital in their outlying counties, and they do not have money for gas. So a 20-minute phone call just to do an assessment could saves a tremendous amount, not just in terms of finances for Medicare, Medicaid, et cetera, but frankly for them. Imagine for some of our patients, it's a 6-hour round trip. In fact, if I want to go from one end to our clinic to the other, we have a clinic in Memphis, clinic in Chattanooga, and then a Knoxville and bordering North Carolina. It's 8 hours. I can get to Detroit, Michigan in 8 hours from Knoxville. So, we have to recognize that we're serving a population that's heterogeneous, not in terms of access to resources, in terms of their own comfort level. We are in communities. We have clinics in communities in a public housing facility. They do not trust the internet. And in fact, when we went to do testing, they thought, are you putting, it was a predominantly African-American Black population. And they said, are you giving me a chip? I need to make sure. And because we were trusted, we could do what the health department couldn't. And we know that for them, we just need to go on foot. We need to be in person. But in other communities, we need that flexibility. So I would say that has been one of the gifts in the pandemic. It has kind of forced some regulatory flexibilities that have been absolutely critical for us. And we need all of that at our disposal to provide care to the diverse communities we serve.
Thank you so much. And I think, again, this gets back to health equity. Access equals health equity, particularly when you think about the populations that we're serving. I want to share a quick story that is just literally, I was talking with a health center in the Midwest recently about just their experience with Omicron and this most recent surge and the challenges that they have with workforce, which was then intensified again because of this recent surge. And in particular, in their case, they were having real challenges when the public schools had to go back to virtual. And a number of their MAs in this particular case were being put in a position where they couldn't come to work because their kids were home. And what do you do? And so this particular health center set up a virtual school environment in their boardroom. And they put facilitators in place to help these kids so that their MAs could come to work. And again, this is what health centers do. But to your point, Dr. Khatri, I think, this is 2022 in America, and I think we can do better. And I applaud this particular health center. I knocked my socks off, although we hear these stories over and over again. And again, it's all about access. And it is all about the health center mission to make sure that that access exists for these underserved communities, which then translates to health equity. I want to turn it over to Carrie to get her kind of experience around this and just, what would it look like if we had that magic wand?
I would echo what you said. It's all about access, and access means less barriers for our patients and for us. The reality for our patients is many of them don't have transportation, and many of them don't get paid when they're not at work. So historically, we have 14 transportation vans doing door-to-door service for transportation to get patients to care. We're open 7 days a week. We're open till 9 or 10 p.m. at many of our sites, which is great. But if you can allow telephonic care when it's appropriate, that's one less barrier for our patients. And while we're happy to stay open till 10 p.m. and transport them to our sites, how nice for them to be able to take time on the phone and stay home and be with their children and be able to make dinner for them or not take time off of work and miss out on pay. Flexibility will allow us to have more equitable care and equitable health outcomes.
Can I add one thing, which is that even in our telehealth models, which are fantastic, we don't actually need significantly less staff. I think that's a myth, that because nobody's checking the blood pressure, I can jump on a call with my patient, Carrie Hydash, and just do my thing. And the truth is, we need folks making the appointment. We need folks, really prefer it not be the clinician spending 20 minutes helping her figure out how to get into that telehealth link and then saying, oh, wait, this has to just be a phone call. Let me switch, because then I've missed several appointments if I do that. And you need somebody following up to make sure the other appointments and lab tests and diagnostic tests and immunizations she needs, which unfortunately most can't be done at home, still get done and followed up on properly. So the workforce issue is still in play, even as our telehealth models expand. I just want to make sure we pointed that out.
No, I'm so glad that you did, Dr. Asher, because I think it's a misunderstanding or a misperception that when we talk about, oh, it's virtual, that just means you don't need as many people. In fact, it's the opposite. I think you actually need more to support. I know there's a question that came up about just specifically sort of what exists out there in current policy. And I just want to kind of reiterate that the Build Back Better Act does include really critical funding for health center infrastructure, for workforce development. But the issue obviously is that it's very unknown about the future of that package. And The specifics around that is that it's $2 billion included for health center infrastructure, $3.37 billion included for the teaching health center program, $2 billion for the National Health Service Corps, and $2 million for the Nurse Corps. Now, all of these programs are absolute priority, critical, and urgently needed for the health center program. I would just call out that there was a study done, sort of a review done of true needs for infrastructure across the health center program. This is going back several months to last year, but they estimated the true infrastructure needs to bring health centers into this present moment and get them fully up to speed. The estimation was actually somewhere in the range of $18 billion. So these investments are very important and more urgently needed than ever before. But the reality is there's so much more that needs to be done. The other piece that I would just call out, kind of going back to sort of the list of policies that we are proposing through Advocates for Community Health, is that the teaching health center model is wildly successful. And we know it and we've seen it, but there are barriers in place right now preventing health centers from fully realizing the potential and the success of that program. And so, again, integrating FQHCs more fully into graduate medical education by reducing those barriers and providing incentives for FQHCs to be able to partner on GME funding is another very big part of what we're in need of right now. But a lot of work to be done, and grateful, that we have that deep bipartisan support in Congress and across the administration, the present administration, and even those historically. In our last few minutes here, we only have a couple minutes, unfortunately, but I want to just ask our panel, health equity has been such a central part of health centers and the work that is in place always. But I'm curious, and a part of our missions, I'm curious if you see health equity and workforce development intersecting, and if you can just really quick, take a minute to speak to that. So Dr. Asher, we'll start with you.
Okay. The first thing I just want to say that in this country, we believe in equitable schooling, right? K through 12. We believe in equitable access to library books. I can't go to school if I'm not healthy, right? And I can't go to school without my shots, and I can't worry about reading if I don't know where my next meal is coming from, and I don't know if I can afford my medications, or I have to choose medications over a meal, or vice versa. Feed my children, take my heart medication. So I think the question about, equity, really, health care and health need to be a right and not a privilege. And when we value that as a right, we will value the workforce, right? We will decide that minimum wage isn't enough for our workforce, and we will reimburse healthcare services at a rate that allows us to pay staff what matters, right? I think for me, they're completely intertwined. There's no way to separate workforce from equity. And again, much of our frontline staff comes from our own community, right? They live and breathe our work. They live and breathe their families or our patients, their friends or our patients. They are trying to take care of their community, and they are trying to give that access to their community. But we need to make it a living wage. We need to make it something they can actually do. At Sun River, we were proud to offer a $15 minimum wage within our organization about 7 years before that was even discussed in New York State. But as that gap is closing, we can't afford to increase again. And so again, we're not competitive. And without a workforce, there is no access. So there's no separating the two.
100%. Dr. Contri?
Yes, I would agree. We know from the data that communities, populations actually respond well and have better health outcomes if they have a provider who is from their community, from their population. And so if we are really going to address building a diverse workforce, we're going to have to build, again, the infrastructure and support that community health centers have. So we are just not able to be competitive. You know, the demand for us is, you know, be the public health system. So we really have been the public health safety net across our country. But at the same time, as Dr. Asher says, we have the demand of being a safety net, but we do not have the infrastructure of a government or a true public health funded program. So we have the market pressures of being a private practice, and then we have the demands of being a safety net. And so really for us, we want to hire from the community, and we have people who have made that commitment, but it's a sacrifice. And sometimes we have doctors and psychologists and clinical therapists who say, I want to work here so bad, but I am being offered X amount at another setting, at the VA or at a private practice, et cetera, and I can't make it work. So they're looking at shifting and literally flipping the status for their family out of poverty. And we want to be able to help them do that. And we can't because of the market, because of the issues, you know, poor reimbursement. Certainly for us, we did not expand Medicaid. We just do not have the resources to be able to do that. But if we do, I think it would be a game changer in terms of diversifying the workforce.
Thank you. And Carrie?
Our health outcomes, equitable health outcomes, and workforce connected? Absolutely. I mean, obviously, the patients that we see need skilled clinicians working with us. But I also the other day walked out of my office and the community health team was creating their outreach plan for the year. And they were talking about social determinants of health. They were looking at health status in communities, and what some of the biggest gaps were as they decided where they were going to go. If we're going to address all of the things that impact mortality and morbidity in a community, we need a robust team of skilled employees across the gamut. I need someone to staff my bookstore. We need someone to staff the community gardens. We need outreach teams. We need health educators. We have to build that workforce, and we need to be able to give them a living wage because they deserve that as well.
Well said from all of you. So grateful for what you're doing, your teams. You're literally keeping our country going. So I know we're over time. I want to say thank you so much to everyone who joined us today and our panelists. I hope you'll join us as we continue to advocate for underserved communities across the country and urge for investments in these uniquely valuable health centers that we've just talked about. If you need more information or you'd like more information, I hope you can visit advocatesforcommunityhealth.org. There's lots of information contained there, and certainly please follow up with us coming out of today's event. So again, a huge thank you to our panel, to the Press Club, and to all of you for joining us today. And be well, stay safe, and thank you again. Take care.